Neurology Quiz number 73. Discuss the clinical features, pathogenesis, and management of impulse control disorders or ICDs in Parkinson's disease, PD. ICDs are behavioral disturbances in which a person fails to resist the drive to behave in ways that result in distress or impaired social or occupational functioning. In PD, ICDs are closely related to the use of dopaminergic medication. The common ones include pathological gambling. This is characterized by an excessive and uncontrollable preoccupation with gambling and the excitement that gambling with increasing risk provides, despite financial loss and social problems. Compulsive buying. This is defined as irresistible excessive buying that can lead to psychological consequences and financial debt. Hypersexuality. This implies increasing preoccupation with sexual thought, excessive sexual needs, increased use of pornography and self-stimulation, seeking out prostitutes, sexual fantasies and exhibitionism. And binge eating. Binge eating or overeating involves uncontrollable consumption of large amount of food, which can result in harmful weight gain. This graphic shows the common ICDs and how such uncontrollable repetitive behavior will lead to an impaired quality of life. Less common ICDs are punding. This is a stereotype behavior that is characterized by an intense fascination with a complex, non-goal-oriented repetitive activity. Examples include repairing, dismantling, putting together and work on projects or cleaning, tidying, and sorting objects. This phenomenon was first reported in amphetamine and cocaine abuse. Dopamine dysregulation syndrome, which is also called DDS or compulsive medication use. This describes a repeated, unnecessary, and harmful daily intake of dopaminergic agents in excess of the required dosage, leading to severe dyskinesia, hallucinations, confusion, and psychosis. More than one ICD can be present in a patient. Epidemiology and risk factors. The incidence of ICDs in PD is not exactly known. The reported prevalence varies widely from 14 to 40%. Studies have shown that the rates of pathological gambling and hypersexuality in the general population is 2 to 5%. In the largest multicenter study of ICDs in PD, the Dominion study, these disorders were identified in 14% of patients on any dopaminergic medication and 17% of patients treated with a dopamine agonist. They were more common in patients treated with dopamine agonists, and the prevalence did not differ between pramipexole and ropinirole. The association was dose-dependent for levodopa but not for dopamine agonists. Long-acting pramipexole and transdermal rotigotine were less likely to be associated with ICDs. This graphic shows the incidence of the most common ICDs in PD in the Dominion study. Other risk factors. Besides medication, other factors associated with ICDs include age less than 65 years, male sex, being unmarried, ongoing cigarette smoking, living in the US, family history of gambling problems and alcoholism, depression, anxiety, and OCD symptoms. There may be a genetic component, as some studies have shown heritability of ICD in PD to be more than 50%. This graphic shows the risk factors for ICDs in PD. Pathogenesis. Imbalance of the dopaminergic systems in the brain are thought to lead to the development of ICDs. There are three main dopaminergic pathways in the CNS: the nigrostriatal pathway, whose axons terminate in the corpus striatum; the mesocorticolimbic pathway, also known as the reward system, projecting from the ventral tegmental area to the limbic system; and the tuberoinfundibular pathway, projecting from the hypothalamus to the pituitary gland. Of these, the mesocorticolimbic pathway seems to play a key role in the generation of ICDs. Normally, in anticipation of a reward or when receiving a reward, there is phasic dopamine release from the VTA, which mediates the pleasurable component of the reward. When a reward is not received, phasic suppression of dopamine occurs, leading to modification of behavior. In PD, use of dopaminergic agents corrects the deficiency in the nigrostriatal pathway but leads to overstimulation of the reward system. Consequently, there is reduced ability to learn from negative events, which facilitates the development of ICDs. Of note, ICDs can occur with dopaminergic agents in RLS, indicating that PD pathology may be important but not crucial for development and expression of ICDs. This graphic shows the three main dopaminergic pathways in the CNS, with A, the nigrostriatal pathway, B, the mesocorticolimbic pathway, also known as the reward system, with cell bodies in the ventral tegmental area whose axons project to parts of the limbic system, and C, the tubero-infundibular pathway. Management. A key element in prevention is patient and family education concerning potential risks of different dopaminergic therapies. All patients should be screened for ICD symptoms. It is important for caregivers to communicate these symptoms to the physician. If the patient does not want to reveal that these behaviors are problematic, physicians should be aware of predisposing risk factors such as young age, early PD onset, lengthy disease duration, history of addictive behaviors, male gender, short-acting dopaminergic drugs, etc. ICDs often start when dopaminergic medications are increased or when a second dopaminergic drug is added. Therefore, the physician should continue to ask a patient or caregiver about ICDs at follow-up visits, especially after dose changes. Pharmacological treatment. ICD symptoms improve after decreasing or discontinuing dopamine agonist treatments, although it may take up to 12 weeks to note improvement. Often this is challenging as the motor disorder of PD can worsen. When ICDs are provoked by dopamine agonists, the patient can be switched to levodopa, and entacapone can be added to prolong the effect of levodopa. In patients with PD who have ICDs, this can be associated with the development of dopamine agonist withdrawal syndrome, which is characterized by craving, autonomic, and psychiatric symptoms. Amantadine has been effective in improving ICDs in patients with PD, but itself has been shown to be associated with increased risk of ICDs. Other medications evaluated, including citalopram, quetiapine, clozapine, naltrexone, sodium valproate, have shown inconsistent results. Non-pharmacological treatment, DBS. Studies of DBS of the subthalamic nucleus, which allows decrease or stopping of dopaminergic agents, has shown that it can improve ICDs, but DBS can also induce specific forms of impulsivity. Other studies have shown no difference or worsening of ICDs after subthalamic DBS. Cognitive behavioral therapy has been associated with significant improvement in ICD severity. It may be used as adjunct or primary therapy, and larger trials are needed to assess its effectiveness. Behavioral measures are important because they can prevent some of the consequences of ICDs. These include taking away credit and bank cards and limiting account access in the case of gambling. Restricting use of internet and video players can help in some cases for hypersexuality.